25th meeting, and I'm glad to. This one, okay. Thank you. We're going to talk today about some experience that I've had in combining my data with Dr. Ossi in São Paulo for a presentation and publication that's forthcoming. But we want to share with you today the data on what it's like to treat people with chronic caval lesions, not acute. Some are acute on chronic, but the ones we've treated have been very chronic, present with very bad legs, and when you put them on the table, they're very purple and discolored and very symptomatic. Excuse me. The list of things that we use in the Andra suite to do this are common things that we use. I find the Roadrunner the most effective wire. We use wall stents in our lab. But the cases that I present here and show you, like this man who had a caval occlusion after he had an aortic bifam bypass, are standard therapies, but what isn't evident in the talk is the fact that it takes about a week to do a reconstruction of a cava. You see here on the left a chronically occluded cava in a young man that I treated 10 years ago. He had single kidney. It was probably there when he was born. The reconstruction you see on the right is a very good result that has lasted almost 12 years now. He's come back for restenosis, which I'll show you. The other case that I present here, which is a chronic occlusion in a woman, postpartum DVT, an attempted filter, a thrombosed filter, 2 years of very symptomatic bilateral lower extremity edema, and reconstruction with wall stents in a configuration that is what I call the double barrel pattern. You see, the IVUS pattern, when you go into one of these chronically occluded cavas, shows you a whole lot of echogenic material, which is not very easy to angioplasty, but you can soften it up with lytic therapy. And this is what is not intuitively obvious to most people. And it allows you to get the wires through the fenestrations and then put a stent in. It looks like this when you finish. So amplifying the lumen that much really makes a huge difference in the outflow. That's why these stents stay open long term as well. So this is the double barrel configuration, or excuse me, the upside down Y, where you put a large stent in the cava, in the infrarenal cava usually, and then iliac stents, which are kissing, going up to that stent. I don't like this system too well. It doesn't overlap very well. The stents don't come together very well. It leaves room for restenosis. On the other hand, this double barrel pattern, which we can extend up above the renals if necessary and through a filter if necessary, has the problem that sometimes where they cross the bifurcation, the stents get somewhat narrow and it's hard to angioplasty them open at that point. And this is a nice 3D reconstruction of one of the most recent cases I've had of a 14-year-old girl who has an azygous continuation of her cava, and she ended up with a prodrome of chronic symptoms for a long time that no one understood, and then presented with an acute thrombosed DVT and bilateral iliac DVT on New Year's Eve this year. So she has a good result. We don't like to put stents in that young of a person, but the results for her will be better than leaving her without a cava. So there's a lot of literature now about caval stents, but most of it does not pertain to very chronic stents. This one from the Mayo Clinic does show that stenting decreases venous claudication associated with iliocaval occlusion, but it does result in some reflux, so compression stockings are a must. Most recently, Dr. Nagel and Raju have published an article about stenting through filters, which we've been doing too as well for a long time, but they had 25 chronically occluded caval filters. They showed that the patency rates with a filter are much lower primary patency rates than without a filter. That pertains to the fact that when people thrombose their filter, they usually have a lot of extra disease that you have to treat. And treating the entire limb from the toes to the cava is the important thing in determining the secondary patency. Now in our data, we have 46 patients, 29 men, mostly men, more than women. The mean age is 40. We have treated very few people with a malignancy. Most of the patients have the entire cava The infrarenal cava is involved rather than the entire cava, but the infrarenal cava will be chronically occluded up to the renals. And the occluded filters that we've traversed are included there with 1 ligation and 1 DeWeese clip. The mean duration of symptoms has been 7.5 years. The documented thrombophilia is relatively small. I think we don't capture all of that. And most of it is bilateral iliofemoral DVT associated with a caval lesion. And of course, the unilaterals are mostly on the left. Acute unilateral DVT is actually less of a common presentation than you would think. And most of these people have post-thrombotic syndrome. Back pain is a real common presentation, and it's missed by most ER doctors. Non-healing ulcers have been seen in young patients. Abdominal collaterals are seen in about 1/4 of the patients. Varicose veins are seen in about 50% of the patients. So these prodromal abdominal collaterals are a good sign, but 2 of our patients just presented with hematuria because of the venous congestion around the prostate and the bladder. The CAP classification shows that a significant portion of ours were 5 and 6. We've had almost every complication we can, with no deaths, thankful. The hematuria UTI infections are the most common infections, and a few of them have only happened once or twice, and we've avoided it in the future. The primary patency is very high. 70%, actually higher than that is the assisted patency because of the restenosis issue, which is about 20% of the patients. The clinical score, as you can see, improves significantly when you open up the flow. The disability score also significantly improved, and the disability score doesn't really depend on acute versus chronic, though it's a little bit better with acute thrombosis on top of a chronic. Restenosis is an issue, and I want to show you just a little bit. We see that with IVUS. We investigated this patient who actually restenosed only on one side, her bad side. No one can really understand that. You can see the intimal hyperplasia within the stent. You can measure the pre and post angioplasty. We really don't have very good tools for dealing with this. This is this first patient I showed you with a caval occlusion, and you can see when he comes in, he has a flat line, loss of phasicity, showing a severe amount of restenosis there in that external iliac portion. Angioplasty does a little bit. We used a Silverhawk to take out some of that, and you can see where the bites were made. And you see, we really are lacking the tools to deal with the restenosis. That's the bad news. The good news is it only happens about 20% of the time. So if you treat the entire leg like we do with thrombolytic therapy, and you get good inflow and good outflow, which obeys the laws of bypass surgery, I think, you do, and we do keep these people anticoagulated, you can have a very good long-term result with caval stents. And I think this is good long-term follow-up. We've been seeing these patients now for almost 18 years, some of them. Thank you very much. I appreciate the opportunity.